So welcome to this symposium sponsored by Abbott. So the title is How to Optimize the Clinical Outcomes with the latest generation intra-annular self-expanding TAVI devices. You've seen a superb live transmission for those who were in the main arena with the Navitor platform, and it was a very nice introduction to what we can expect and achieve with this platform. So my name is Didier Cheche. So I work in France, Toulouse, and it's a great pleasure to co-moderate this session with Yoe that you all know, Yoe Hono, the local guy. And then we will be helped today by four of our friends, so Angus Shui, Vinny Bapat, Minoru Tabata, and Gaku Nakazawa. So there are a couple of objectives related to this self-expanding platform that you are more and more aware of, and the idea is to getting used to that platform to understand what it can help in daily practice to address some specific patient population. And here today we're going to discuss a couple of things. The first objective is try to understand how the clinical outcomes can be impacted by the choice of the TAVI platform and the features of the platform that we're going to use for a particular patient. The second one is to try to understand how we can navigate in some challenging situations. And at last, during the live case, we've addressed this type of issue considerations, lifetime management of the patient, potential for a redo procedure, and what do we do to prevent conduction disturbances. This is quite a very dense, robust agenda, so it means that we will have a very nice discussion. Once again, it's a relaxed atmosphere. We are in a quite decent-sized room, so guys, embrace that session. This is really a session for you. We want to get to know what you have in mind, what you would like to understand, what you would like to be expressed and discussed here. So feel free to raise your hand. We have these catch boxes that you well know. We have microphones. If you just want to come here and take our place, you are welcome. So feel free to do whatever you want. Okay, so having said that, I guess we can, Yoe, do you agree we start the session?
Sure, why not? So interaction is the key for this success for the session, so please don't hesitate to come up with all your practice, share your experience and techniques. So let's start with the first speaker. I would like to invite Virag Kurswal to present his topics, how to navigate in TAVI patients with challenging anatomies.
Thank you very much, Yoe, and thank you to the panel. It's a pleasure to be with you all here in Tokyo. It's been a really great couple of days so far, very enjoyable. And we just saw an excellent live case and demonstration of this valve. For those who are in the Tokyo room, Kentaro did an amazing job. So my brief today is to talk about how to navigate in TAVI patients with challenging anatomies. So I'm going to go through some different challenging anatomies, and we will discuss how this platform works. I'm based in Sydney in Australia. These are my conflicts of interest. So what is challenging anatomy, and what challenging anatomies that we deal with? I think we can break this up into femoral access, where we see tortuosity, calcification, small caliber vessels, anatomical issues with the aorta, tortuous aortas, Gothic arches, calcified craggy aortic arches, and as well as rarely coarctations, particularly with bicuspid valves. And then, of course, challenges with the aortic valve complex, horizontal aortas, those with heavy calcification and bicuspid valves. There was an excellent session on bicuspid valves earlier this morning, and small annuli, which my colleagues are going to talk about later. We have to deal with all of this, and while doing this, we're expected to get procedural success, yet we need a platform that delivers a valve which gives us excellent hemodynamics. We don't want to see any significant paravalvular leak. We want to achieve low permanent pacemaker implantation rates, and we have to be mindful of the lifetime management, which is a theme that we've been seeing through this meeting. This is the Navitor Vision valve, and this is a really smart, intelligently designed valve that has great practical utility. It's got a very large cell design to allow easy coronary access. It's got a very large range of annuli that it can treat, down from a 19 millimetre with a 23 millimetre valve up to 30 millimetre diameter annulus with a 35 millimetre valve. It's got an active sealing cuff which expands during diastole, which really mitigates and seals off paravalvular leak, as well as in combination with the large cell design which can mould to calcium within the annulus complex. It's got a very good radial force, although the opening force may not be as high as other self-expanding platforms. It's got an excellent radial force that's nice and consistent and provides uniform expansion during deployment. The the leaflets of the valve are intra-annular, and this allows for immediate function of the valve during deployment and real hemodynamic stability, which is really important for high-risk cases, particularly those who are frail and have poor left ventricular function. And the main addition with Vision is the addition of these 3 radio-opaque markers which sit under the commissures. They're very easy to see and visible, and the bottom of these markers is 3 millimetres, which certainly helps not only with trying to achieve commissural alignment, but getting our depth implantation. And from what we've seen, Navitor performs really well. It does give us excellent hemodynamic results. And irrespective of which valve you choose, i.e. small valves or larger valves, you get excellent reductions in gradient, low single finger gradients, as well as increases in the effective orifice area without any significant paravalvular leak. And we've now got data up to 5 years showing that these valves perform very well hemodynamically. I think what's probably most relevant, though, for what I'm going to be talking about is deliverability of this valve. And the real game changer with this platform has been FlexNav. The delivery system has an integrated sheath, which is either 14 or 15 French, so 14 French for the smallest size of valves, the 23 and the 25, and 15 French for the bigger valves. It's got a very soft atraumatic nose cone, which allows navigation through tortuous anatomies, as well as atraumatic access into vascular structures, particularly useful for alternative access cases. It's got this stability layer, which means you really get precise precision deployment without much movement of the valve at all. And the great flexibility of this system is achieved by the fact that there's no actual metal spine within the system at all. So it's very flexible and probably the most flexible delivery system we have. What are the challenges within femoral access? Well, we've got tortuosity, previous endovascular procedures, particularly AAA repairs and stents, high degrees of calcification, particularly concentric calcification or diffuse, and size. And really, when picking a platform that has these challenges, you want to have the most deliverable platform that you've possibly got for a challenging small anatomy. And that's what FlexNav and the Navitor platform offers. Now, it's not just enough. We can't just treat these systems with just picking the right valve. Obviously, we need to have additional techniques and tips and tricks. And I think one of the game changers in terms of transfemoral TAVI has been tackling these calcified cases with intravascular lithotripsy. This has certainly decreased our alternative access use significantly and allowed for much safer transfemoral access. But even if you are applying these modification techniques, balloon angioplasty or lithotripsy, you still need a very deliverable system. And then, of course, when considering these complex anatomies, there is always alternative access, whether it be transcarotid, transaxillary, or there's few centres that perform transcaval. The aortic issues that we need to deal with and we need to think about with TAVI are, again, related to tortuous anatomy. So if you've got a very tortuous thoracic or abdominal aorta, you've got a very high arched angulated Gothic arch, then when you get down to your valve complex and you're pushing on your valve system via the femorals, you're transmitting a lot of these forces through the hinge points of the valves. And so you want a delivery system that requires the least amount of pushability to track around this to prevent trauma to the aorta. And the force that you deliver is definitely at these weak points. You can cause dissection, you can cause rupture. I've caused one rupture with a Gothic arch, and thankfully there was salvage for the covered stent, but it can be fatal. I think aside from one of the things that's changed a lot in our practice is if we encounter these very difficult anatomies, particularly in the aorta, one of the safest things to do is actually to introduce a long gore sheath, which sits past all this tortuosity, so you only have to navigate it through once. And then use a system which is going to slide within that simply to get across the annulus and complete your deployment. And of course, transcarotid and transaxillary alternate access. Horizontal aortas can be difficult with self-expanding platforms, but if you've got a very deliverable system that allows you to be coaxial, and we saw one of the great tips with implantation from the live case was to start your deployment a little bit deep, flare the valve, and then pull back the valve so that you maintain coaxiality. Not only maintaining coaxiality, you allow uniform expansion of that valve, so the valve deploys radially. And you can get very precise, slow, controlled deployments, even in very horizontal aorta anatomies. Why is all this important? Well, it affects outcomes. So the more complex your access is with combination of the femoral access, the aorta, and the aortic valve access, much more likely you are to end up with vascular complications, and certainly there's a much greater trend towards major adverse events with the more complex anatomy we're dealing with. So I might just share a case just to give you a flavour of where I think the valve works really well. So this is an 85-year-old man, New York Heart Association Class 3 dyspnea. He's got symptomatic severe aortic stenosis with a valve area of about 0.7. His perimeter sat at around 82 millimeters of mercury with a valve area of 535, sitting in for a 29 millimeter valve. What's important with this case is the comorbidities. He's had previous bypass surgery, 2 vein grafts, no lemur to his LAD. He's had peripheral vascular disease with bilateral fempop bypass and lots of scarring. He's also had bilateral carotid endarterectomies. And if you look at his femorals, if I can just stop it and scroll through, you can see there's extensive iliofemoral calcification, which extends just above the puncture point all the way up to the descending aorta.
Would you stop here, maybe a little bit backwards, and just to see, to understand from the audience the options for this patient. So here is it's a type of patient that we may encounter because sometimes we are treating very challenging patients, and there is often that issue of the feasibility of the transfemoral access, and if so, the device that we're going to use. If you could play again the CT loop. First of all, let me try to better understand who you are, guys. Who is an interventional cardiologist here in the crowd? Raise your hand. Interventional cardiologist? So you are going to be on fire, put on the spot. Who is a echo specialist? Okay, so the other ones. So, okay, the question for you guys who are interventional cardiologists, do you think that this is feasible? Dr. Kim, Professor Kim, do you think that this patient could be a suitable candidate for a transfemoral access?
What kind of answer do you want? I think it is very difficult to do a transfemoral approach.
It's challenging.
Yeah, transaxillary is a good option for me. Transcarotid is a little bit invasive for us. Of course, neurosurgeons say it's very safe, but to my emotion, I think transcarotid, I try to avoid that.
Okay. So you would try an alternative access, and which device, even if we are mainly focusing on the Navitor vision, which type of device would you use? Do you think that Sapien, Evolute platform, or something else could go through this?
I prefer Navitor or Evolute.
Navitor, self-expanding platform.
Yeah.
Thank you. And you guys, any other option? Vinny?
That's what we are discussing here is if femoral is not possible, important thing is a safe alternate access. So in our experience for now is mainly carotid. This patient had bilateral carotid endarterectomy already. So from that point of view, he has now good collateral on the other side. So I don't mind doing it. But if the option of percutaneous axillary is there, then probably that's a preferred approach.
Okay.
Provided, of course, there's no risk for that.
Any other view? Minoru, you are a surgeon. Would you do the same?
Well, I just agreed with the previous surgeon's comment. And nothing to add.
Gaku?
I think I would go with the carotid.
Carotid.
Yeah, because this one, maybe you can pass, but you don't want to have a hard time doing this, passing the iliac artery. So I don't want to waste time for here, so I just go with carotid.
And you, Angus?
Yes, I agree. Although my friend may always ask whether to do a transcaval,
Yeah.
but from this CT, I don't think this is a good spot for transcaval access. And with previous carotid endarterectomy, I agree the transaxillary may be a better one.
Okay. So,
So that was pretty much our feeling. So we thought may be possible to do transfemoral, but with great difficulty. We would almost certainly need intravascular lithotripsy, if not stenting, by a vascular team. So a very extensive procedure. And it was his diagnostic angiography, which he previously had femorally, was difficult, where they kinked the sheath. They weren't able to even get a 6 French sheath in without using stiff catheters due to all the extensive scarring. So we were turned away from that. Most of our alternative access these days is transcarotid. This was kind of in our earlier days of our transcarotid experience, and our surgeons thought that with the previous endarterectomies that perhaps transaxillary would be okay. Now, I haven't shown you the axillary and subclavian, but the axillary and subclavian were actually good quality vessels without calcification, but they were relatively small, so about 5.5 millimeters. So we thought we'd pick a low profile 29 millimeter Navitor valve. We do most of this percutaneously, and for this case, given the difficulties they had with the femoral angiogram, we chose ipsilateral left radial access as well for our pigtail, and also just to help us with bailout if there was any any vascular complication. We then introduced the valve after a gentle predilatation, and it's very easy to advance this through even small axillary subclavian system, and as with a lot of alternative access, its precise positioning is certainly very possible, very much so with this valve. We then went through our very, a routine slow deployment. I think we paced at about 100 beats a minute during this case, and you can see how well and how uniformly the valve expands slowly. The deployment is very controlled. You've always got hemodynamic control. This is an awake patient who you can talk to throughout the whole time, and you want to make sure that they don't get panicked during the procedure. They are high risk, so it's really useful to maintain their hemodynamics throughout deployment. And then we can see that the valve really doesn't move. We've got a very nice position in the end, sitting at about 3 to 4 millimeters depth uniformly. And you can see how central that was. There was a little bit of paravalvular leak, as well as some bunching of the cells on the non-coronary cusp. So we gave it a gentle post-dilatation with a 23 millimeter balloon. And the final result was certainly very good.
Yeah.
We then did a dry closure just with a 6 millimeter Armada balloon at low atmospheres. At this stage, we're still using 2 ProGlides. Now we just use one ProGlide plus or minus an angiosil if required, and we ended up with a good result. So just to summarize where, I think Navitor and FlexNav definitely excels when you've got difficult access, marginal access, or extreme tortuosity. It's incredibly deliverable. It's got a low profile. It's got an atraumatic entry into vessels and allows for precise deployment. Certainly in horizontal anatomy, it's very predictable. You can centralize the delivery catheter very easily, and you can maintain neutrality of the delivery system. And definitely during alternative access with small vessels, it's atraumatic and it allows for a very stable deployment. So, thank you.
So a very nice overview of what we can achieve with this FlexNav catheter and the valve. So let me try to understand, who has ever used a Navitor or Navitor Vision here? Raise your hand. So a couple? Okay. Mm-hmm. And so in your experience, do you agree with the concept of potentially a greater flexibility or high level in terms of accuracy of efficiency in tracking of the FlexNav? Is it something that you have experienced if you compare that to other platforms?
Yes, I think it's quite simple. Yes, we did experience that compared to the Evolute, the flexibility is the variability is quite well. And also, given that the profile is also quite small, so for majority of the particular cases, we usually will maintain the femoral access if it's potential possibly feasible. For this case, given that recently the lithotripsy is also available in Taiwan, so maybe we can. We also have. There are also many cases reports showing that maybe the lithotripsy can improve the femoral accessibility. I think especially for this small profile and also very flexible delivery system, I think quite well.
Okay, thank you. There is one concept that you have brought and that you just mentioned, the lithotripsy. So it means that we are pushing the boundaries, Yoe. Is it available in Japan?
Only for the coronaries at this moment.
Not for the peripheral. I guess in the US or other countries it's available. Maybe it could be interesting for the audience to better understand where we position that device. How do you use it in your practice? Is it for circumferential, 270 degrees, 360?
Yeah, so certainly if you've got circumferential calcification in a small vascular size, so less than 5 millimeters, lithotripsy is excellent. If you've got even smaller anatomy and 270 degrees of calcium, so between above 4.5 to 5, then I think it's very useful there as well. The couple of times when we've struggled have been when we've had extensive, more than 20 millimeters length of calcification, where we've certainly managed to get our system up, but we've required stenting to bail out the procedure at the end due to either a small perforation or extensive dissection from the ballooning. So it makes transfemoral achievable, but I think these systems are so good and so deliverable, and we improved our techniques with percutaneous access so much that I don't think we should shy away from percutaneous, alternative access.
Yeah. Be careful, we have surgeons.
We shouldn't shy away from it at all, and particularly with transcarotid these days. They're some of the most comfortable procedures that we all do, mainly because we just step in, deploy a valve, and step out, and the rest of it's left and dealt with by someone else.
So yeah, please go ahead.
I would like to also share some of our experience with IBL over those tortuous calcified femur. Because previously we have a very bad femur, both tortuous, diffusely calcified with both concentric and eccentric calcification, and we try to use an IBL and crack open it and put in the TAVI device. Unfortunately, the IBL balloon ruptured over the turn with this eccentric calcification and causing bad perforation of the femoral artery, we need to have emergency cover stent. We have a lot of discussion whether we still need to proceed or change to an alternative access. But luckily, the flat snap catheter can still manage to cross those tortuous or this stent vessel. So it's really good for the flexibility.
So Virag, a quick question which will be really important is, you pre-dilated and post-dilated. So what sheath size are you using and which type of sheath you will recommend?
So most of the time we are using, we actually use a Medtronic Centrant. And depending on what we're using, it's usually a 14 French sheath that we're putting up. If I'm concerned about the vascular access, then I tend to use a Gore dry seal sheath, which is much more flexible, and particularly a longer sheath with the potential of being able to deliver stuff without having to negotiate that difficult femoral anatomy.
Other thing, Didier, is very important is I think for transaxillary, the room dynamics are easier. For carotid, everybody is very cozy under the radiation. It can be tricky. So I think, again, our approach is changing slowly to percutaneous axillary for that reason.
I think one of the things that has made our room dynamics a bit easier is we actually now place the patient upside down on the tape. So sorry, not on their face. So their legs where their feet would be. So the only mindful thing is then every RAO angle will be an LAO and cranial will be a caudal. So, but it just makes it easier. You're standing on the correct side of the patient, and it's much simpler.
And Yoe, maybe one final comment from you, because it's a very interesting discussion, but we always talk about the algorithm, and in the vast majority of the cases, we only focus on the landing zone configuration, the aortic annulus, the LVOT, the sinuses. Is it fair to say that we need to integrate the peripheral vasculature as one of the key components? Because in 80% of the patients, you could use either device, and sometimes it's a peripheral that is going to dictate the device that you're going to use. So in other words, do you think that we can work with a single platform, or should we have at least two different platforms to be able to tackle this?
Yeah, thank you, Didier. It's very important and very relevant for our Japanese population, because most of the time we face borderline peripheral vascular, let's say even a little bit less than 5 that already has mentioned. And I think this platform also goes very well if there's no significant calcification or tortuosity. Even if it's, let's say, around 4.5, it can go. So this is the, I think, unique feature that we have among our available platforms. So always good to have several platforms in our shelves. Yeah.
Thank you. So very nice discussion, but we have to move forward. Thank you. So the next one, I don't really know who he is. So Kentaro is going to drive us through the outcomes in small annuli.
Yeah. Okay, thank you very much, Didier. Nice to meet you. And hello, everyone. So I'd like to talk about how to optimize TAVI outcome in patients with small annuli. Actually, I was a fellow in France from 2009 to 2012. And we had 2 Japanese fellows from Sakakibara Youth Care Watanabe used to work there. And we also have the Masa Yamamoto from Nihon Idai. And now currently they're working in Teikyo and Toyohashira Center. And we published some data using the French data. However, we really need to have our own data. Therefore, we set the Ocean SHG family. And we set it from 3 centers. Nowadays, it's coming to be 30 high volume and volunteer center, including the 330 members in this year. And this is the total number of the procedure. More than 25,000 TAVIs and 5,000 TEER and more than 2,800 appendage closures. A good number to publish some data from Japan to the world. And we already published more than 440 papers, including 15 mitral and 7 appendage closure. Some of them are accepted in the guidelines, like Japanese, not only Japanese, but also in American and European guidelines. So we conducted this study to compare the two self-expanding platform, Navitor and Evolute FX. And this study was conducted using the Ocean TAVI registry. And we did the matching, propensity matching score. And each group has the 300 cases. And if you look at the data, no difference in terms of the body surface area. And annular size is quite similar and very well matched between the two cohorts. And the incidence of the periodization was more noted in the Navitor group compared to Evolute. And the post-dilatation was the more frequently performed in the Evolute group. And the new pacemaker implantation rate was similar between two platforms. And the technical success was similarly achieved in the both devices. And device success was also achieved very similarly between two groups. And if you look at the incidence of severe prosthesis-patient mismatch, there was no significant difference, as well as the PVL equal or more than mild. And the incidence of pacemaker implantation was quite similar, and technical success and device success was similar, even in the overall cohort and the propensity matched cohort. That means the Navitor demonstrated very good hemodynamic performance, even compared with the Evolute. And this is the incidence of the patient prosthesis mismatch. As I said, it's quite low incidence of severe prosthesis patient mismatch. Even with the smallest 23 millimeter Navitor valve, severe prosthesis patient mismatch was noted in only 3%, even though the cohort with small annulus in our country. And 23 millimeter device also demonstrate the very good hemodynamic performance. If we compare 23 millimeter Navitor and 23 millimeter Evolute, the Navitor demonstrates the larger effective orifice area compared to that of the Evolute. That is also very surprising to us. And the mean pressure gradient was quite similar, and the severe PPM was very rare with Navitor as well as the Evolute. And we also compared the Navitor and the SAPIEN 3 UR. So now we're under the way of the comparison using Ocean TAVI registry. But before that, we published the data from our Keio University Hospital. And we compared 53 S3UR and 44 Navitor. And the pacemaker implantation was highly required with Navitor compared to S3UR, leading to a little bit longer hospital stay. However, the Navitor was associated with the lower mean pressure gradient as well as the larger effective orifice area. And the incidence of prosthesis patient mismatch was a little bit lower. There was a trend towards lower incidence of prosthesis patient mismatch with Navitor, and the PBL was the preserved, well avoided with the two devices. And there was some discordance between invasive and transthoracic echo in both S3UR and Navitor. And there was no difference in terms of the leaflet thrombosis between two devices. And in conclusion, ladies and gentlemen, so Navitor demonstrated the comparable hemodynamic performance with Evolute FX in patients with small annulus. And Navitor demonstrated higher incidence of PMI and PVL, but better hemodynamic performance compared with S3UR. And Navitor demonstrated excellent clinical outcome compared with other latest platforms. Thank you so much for your attention.
So Kentaros, thank you so much for highlighting this hemodynamic superiority of Navitor. Even comparing with the supra-annular platform, it was almost equivalent. So very good and positive result. Congratulations. And you also just demonstrated a superb live demonstration for the small annulus patients.
Yeah, with that case, the mean pressure gradient only 9. So that also demonstrates Navitor has really good hemodynamic performance.
So considering these currently available 3 platforms in Japan, the hemodynamics are almost comparable. So what other things would you take into account in terms of valve selection?
Yep, that's quite a good question. Actually, the preventing PBL is quite important, and the deliverability is quite important. As you could say, the Navitor is quite hydrophilic coated and very slippery, and we can negotiate with very poor interfemoral access with Navitor. If the patient had poor interfemoral access, then my first choice would be Navitor. And the coronary access is also quite important. As you might see, it's difficult to adjust the adjustment. However, it's quite easy to get the coronary access because of the intra-annular design and the larger cell.
Yeah, that's absolutely one of the advantages of this frame design of the Navitor. Any other comments to Kentaro's Minoru?
Kentaro, thank you for sharing very insightful data. So I was wondering if you, in your analysis, if you adjust the anatomy, especially like a calcification. So the reason why I'm asking that question is in our institution, Navitor is a first-line device when we see a heavy calcification on the annulus and LVOT. And such a calcification could impact negatively post-procedural hemodynamics. So if you adjust those things, result might be a bit different. What do you think about that?
Yeah, thanks so much, Minoru. It's quite important point. With comparison with the Evolut, it's okay because both devices are used for the heavy calcification with LVOT calcification. But in comparison with S3UR, we usually eliminate the LVOT calcification from S3UR cases. That may lead to the kind of selection bias to see a little bit higher incidence of PBL. With Navitor compared to S3UR. That point should also be taken into account. So that's the reason why I didn't emphasize that much on the PBL compared with S3UR.
And I have a question because it's conceptually it's quite difficult to understand why we achieve such large EOAs and low gradients with an intra-annular valve. Because we can understand the difference between a self-expanding supra-annular and a balloon expandable intra-annular for small anatomy in particular. But here we have 2 platforms. If we speak freely, we have a intra-annular self-expanding and a self-expanding supra-annular. And you showed in your data that the EOA in the smallest devices, 23 and 23, is larger with the Navitor. Do you think that it's based on the construction, the building, the architecture of the device, or what explanation do you have for that?
Thank you. So the first time I heard of the comparison of hemodynamic performance between Portico and S3 in the ID trial, and Portico was associated with the less gradient compared to S3, I thought that it's a mistake or something. However, if I use the Navitor, and Navitor demonstrates very good hemodynamic performance, maybe presumably due to this tube design of the valve. And maybe if we compare the Navitor with Evolut, maybe Evolut has some waste. That could also be the reason why the Navitor has the bigger EOA compared to the Evolut in terms of the 23 millimeter device. That could be one of the reasons.
So very intriguing. Do you have any insights, Vinny? You are a lot into the design of the devices, the circularity.
I think it's very important. And so 15 years ago, I learned from someone very senior in R&D is when you design a stent frame and you have a leaflet, all valves have 3 leaflets, but you can optimize it to a stent frame design and how it involves. And Navitor also jumps in 2 mm sizes. So the way you have to match the performance of the leaflet to the stand frame and also the height of the leaflet. So if you see, the Navitor leaflets are slightly taller than the other devices. So I think all that eventually, in a simple words, amounts to more opening. And that more opening, of course, gets translated into a better EOA and lower gradient. So I think it's 2 mm jump, optimization of the leaflet to the stand frame is quite important. And secondly, now with the new system, you can deliver it in a very stable fashion. So there is no canting or tilting of the device also, which I think matters a lot when we do these measurements.
Thank you. And there is another concept I think it's very important to maybe elaborate a bit on. You said when I have a calcified valve, Minoru, you said that as well, I'm using a self-expanding platform, in particular the Navitor platform. What is the reason for that? Is it because some may say, okay, you may use a balloon expandable platform and you just don't push too much, you underfill. Do you take advantage of the design, once again, of the platform with the open cell? Is it that? Is it the reason, the calcium being better accommodated?
Yeah, definitely, yes. So the larger cell just, catch the calcium very nicely, and the excellent sealing function, sealing system works very well. So that's another reason we choose Navitor for heavily calcified cases.
Thank you. And Kentaro, during your life case, it was, first of all, congratulations again. The outcome was great. You did pre-dilate.
Yep.
And maybe we can expand a little bit on that. Do you always pre-dilate? Do you sometimes pre-dilate more aggressively?
Actually, I think that pre-dilatation is quite important, especially for Navitor, to avoid non-uniform expansion. And I think that if we perform pre-dilatation, we don't lose anything, so just time. So that's the reason why I always do that. And in terms of the size, I usually respect the minor axis of the annulus to avoid acute error. And of course, we still have some time, even though the acute error occur, we gently advance the system, we can gently deploy. However, so I don't like that much causing any trouble, so I stick to the minor axis. And if the leaflet is very much calcified, I usually choose ZMET, that is the non-compliant balloon in our country, because we don't have true balloon or atlas balloon in our country.
Yeah, I think pre-dilatation, the role of pre-dilatation is even larger when we accumulate evidence, mainly from Vinny and Miho's work, dealing with post-procedure CT scan. If the valve is not expanded very well, obviously higher chance of valve thrombosis, which translates to lower durability. So I think Kentaro's strategy will work for a majority of the patients, and I basically do that. But in some cases, we need more aggressive bigger size of a balloon, because even with the pre-dilatation, the valve could not expand very well. So recently, I tend to use a slightly bigger balloon size with regards to the minor axis.
And let me ask you maybe one last thing. You can ask your.
No, I think the important thing is pre and post dilatation. So the practice of pre and post dilatation was very common, and then we had a fear that it increases stroke. So it kind of disappeared after that, and then now it's re-emerging now, because we know that the delivery systems are thinner, smaller, more hydrophilic. So I think the use of pre and post is more liberal now than 5 years ago, for sure.
So given the fact that you have quite an experience, you are quite experienced with self-expanding platforms, and particularly the Navitor, it's a very naive question, and I would like you to tell me what you think about it. Sometimes we know that with the Evolute platform, and that's something that we've observed, you tend to go higher and higher. The higher you are, most of the time, the lower is the gradient, because the EOA is bigger. and you end up with this type of configuration. And you have the leaflets that are here. I'm sorry, but let me draw again. You have something like that. With the navitories, it's a phenomenon that you observe. Sometimes you end up high because that's you're guided by the anatomy of the patient. Do you get the same shape, or does it remain? Oh, I'm so sorry, tubular, despite the. I've broken I've broke the thing.
Yeah, let me start by answering that question. So, as you mentioned, with the Evolute platform, sometimes we see this kind of inner curve not well expanded at the LVOT and annular position, and we notice that it's not a good expansion. So in that kind of case, we either recapture or go for an additional pre-dilatation. Navitor valve, I think, a little bit different from Evolute, the way of expansion, but we sometimes observe under-expansion of the valve in a little bit of a different way. Sometimes non-uniform expansion, sometimes overall a little bit under-expanded valve. So I think the message, as we discussed, to go for other view, sometimes rotational angio would help, and identify those kind of situations that we may need for obviously pre or post dilatation.
Thank you. Yeah,
yes,
please. Use one of the microphones.
Oh, here.
Sorry, just a word of caution though. If you do get that kind of little indentation appearance, usually means you're high with the Navitor platform. And I would recommend not post-dilating in that situation. You will get a pop-up. So just be very mindful of that appearance.
Thank you.
That's a very important comment. Yeah.
Dr. Kim.
There, yeah.
Yes.
Yeah, I'd like to comment on a little bit limitation in Navitor.
Yeah.
The first one is, as mentioned, Vinny, the height of leaflet suture is definitely higher, even though intra-annular design. Thus, we don't be confused with the same intra-annular design such as Sapien. Thus, in this context, we have to consider choice of valve in a very young patients who have a long life expectancy, may future require TAVI and TAVI. The second point is, I think it is very difficult to get good commissural alignment. Even though we can see the left two post on the right one post just before deployment in the ascending aorta. Yeah. It's very difficult. And then after deployment, it always not well aligned compared with the best one is accurate, the next one is Evolute. Thus, I think Navitor should be improved in these regards. The third point that I'd like to ask you, Kentaro, I was surprised the pacemaker implantation rate is comparable but numerically higher than Evolute. Is it
compared with
Evolute?
Evolute.
Yeah. Is it universal data globally regarding Navitor?
I'm not sure, but we use the registry data based on our registry data. So it says so, but we introduced Evolute first, and then Navitor. We're still on the learning curve. We were still on the learning curve.
How about Didier?
In terms of pacemaker differences, yeah, I guess it has to do something with the maturity of the technology first, and then the technique. The valve has been introduced a little bit later on in the learning curve. So for the self-expanding supra-annular platform, integrating the cuspidal projection, refining the way the valve is deployed, starting high and so on. In most of the centers, you can achieve close to 10% or single-digit pacemaker rates. So I guess the more we're going to use the Navitor, the more we're going to get closer to that. The thing is that for the time being, we are not extremely confident in deploying it extremely high. Potentially, as what you did during the live transmission with the ICE guidance to better understand the length of the membranous septum, to try to match the depth, tailored depth for the patient to this membranous septum may be an option in the future. So your point is very well taken. I do agree with the need for improvement in terms of commissural alignment. And for the pacemaker, I guess it's going to be an history of refining the technique of deployment.
Definitely. So
We need to move.
yes, great discussion. So thank you
Thank
so
you,
much,
Kentaro.
Kentaro, for great data. So since Professor Kim kindly raised a question about conduction disturbance, we would like to invite Gaku for providing his initial experience regarding the conduction disturbance.
Okay, thank you very much, Yohei. So I'm going to talk about the conduction disturbance with this device and how to achieve low PPI rate with latest intra-annular self-expandable TAVI device. So Ocean TAVI registry reported feasibility and safety of this device in Japanese patients, especially with small annulus. And Navitor system have very flexible system, delivery system with hydrophilic coating, which allow us to use this device in complex aortic root anatomy. But pacemaker rate is actually relatively high as compared with balloon expandable valve, 9.7% in Ocean TAVI registry in the initial experience. Although the learning curve can be observed, but still pacemaker rate, implantation rate is as high as 8% in later experience. I think all of you know that pre-TAVI assessment of membrane septum length is very important. But this is usually done by CT scan, and we also do that in every case. And if you compare with a pacemaker patient versus non-pacemaker patient, MS length is, of course, longer without pacemaker implantation. So that analysis of membrane septum length is very important. And, like just we discussed, live viewing of the membrane septum by transjugular eyes is very important to reduce this kind of complication. And Yohei and I started this technique, and the live demonstration case did it, right, in this afternoon. And then you can reduce the risk of conduction failure especially during the self-expandable valve. You can appreciate the membrane septum here, and also edge of the device you can see here. So, you can try to implant this device without touching the membrane septum. And this is a guideline of this implantation of this device, which is shown by Abbott. And of course, you always need to predilate the valve. And usually using the cusp overlapping view. And the new system has a marker which tells you which depth are you in, and the marker can be, you can implant decide the position based on that marker, and allow valve to descend to 3 millimeter depth. But the reality is that actually this device tends to be implanted deeper than expected, which leads to maybe higher rate of PMI. I think there are two reasons for that. One is actually non-uniform expansion. And then this is why we go deeper from the beginning. And also another one is the LCC shallowing. I don't know the term is right or not, but that's just I created a term. But that device will be, like a LCC side will be shallow. So I will show you later. So non-uniform expansion is called NUE. Because of the design of this device, non-uniform uniform expansion is reported as one of the complications of which lead to device migration or pop-up when the final device is released. And some of the groups reported that distal opening of this device can avoid this NUE. Actually, Kentaro's group reported, Dr. Kobari and Kentaro reported that distal opening can avoid this kind of NUE. As you can see here, you just go deeper, like 7 to 8 millimeter depth, and open the device distally and pull it back up to 3 millimeter, and then open the valve so that you can avoid NUE. But I think if you do that, like open valve flame just can touch the conduction system, which leads to AV block during the procedure, and that can persist. even after the procedure.
Gaku, if you just come back
Sure.
you see panel D and I.
Yep.
D is too high. The device
Yes.
is bulging into the sinus of Valsalva, and I is correct. But do you think that potentially in the future we could find a trade-off just in between? Because one is really high,
Yes.
and the other one is
Yes.
really safe.
Yes.
Maybe there is. Do you think that we could aim a little bit higher?
Yes. Actually, I'm gonna talk about that later on. But yeah,
Thank you,
that's right. but actually, if you start with 3 millimeter depth and annuli happens, then after the position looks fine during the procedure, but after the final release, it pops up a little bit if you have annuli in your struts. So, but that's why they try to go deeper, and then just without attaching the stent struts to the annulus first. Then because there's already cell open, and then you put it back, so that you can expand the valve well. So that's the technique of this. And then actually, it's not necessary that the panel I is too deep. It's an ideal position, but that can cause AV block. Even transient or not, maybe it's persistent, right? So I think we need to understand annuli more. Oh, can I go on, right?
Yeah, please.
So this is our case. Just this is a perpendicular view pre-TAVI, and we perform TAVI with 80 millimeter balloon. And implant valve with cusp overlap view at the depth of the 3 millimeter. Looks fine. The depth looks fine. And this is angiography just before the point of no recapture. And I felt something wrong with this appearance. You see a lot of, the stent struts densely populated on NCC side.
Do you agree, Angus?
What do you think?
Angus, you're nodding. What do you think about that position? I'm a little bit worried, but maybe I'm too scared.
Angus, any opinion from your side?
I'm not sure. I'm not sure whether it is the parallax problem, because you see this one of the dot is a little bit higher than others. Yes, I think this still. Although a lot of time we use a couple of language, we claim that parallax will be soft. But for some patients, I know why, but there's still some parallax when you open up the stent. So I guess this is a parallax problem. So if we see that, sometimes I will change the angle of the imager and to correct the parallax and to have a better assessment.
Yes. Actually, this is my kind of early experience, but I felt something wrong, and I thought that might be annuli. So I just recapture and then replace it. This is second attempt. But the position looks similar compared with the first one. But when you look at the angiography, to me this looks fine. Do you agree, Yohei?
Yes.
Right.
Well expanded compared to the previous one.
So often, when talk about annuli, often people talk about only NCC side. But if you look at this is a final, actually, right? Looks okay.
Perfect. No.
Yeah, perfect, right? Okay. So when we talk about annuli, often people talk about the only NCC side. But if you look at the other side, opposite side, expansion is totally different. So that means if you have a lot of stent struts in NCC side, it has less struts on the other side. That means it cannot be expanded. But the second attempt, you can appreciate the stent struts reaching to the RCC, LCC side. So I was sure that I have already, my device in a good position. So that's why I just released it. So I think the assessment of annuli is very important. Then if you concerned about annuli too much, you go deeper. So that's not good. And actually, steep RL view is very good projection to assess this annuli. Dr. Kaneko from Hachinohe Sensei's group reported that steep RAO is an ideal projection to see this kind of under expansion of the stent struts. And then they proposed that when you see the NUE, maybe you capture the device and replace it, and or additional pre-dilatation with larger balloon, or you undersize your device because the stent cannot be expanded. Maybe you can understand. You can undersize the balloon, not bulge. That would be the option. But if you can assess NUE correctly, I think this opening is not needed, so that you can maybe reduce the incidence of pacemaker implantation. And also another one is shallowing in the LCC side. So this is a cusp overlap view. The other case, but you see the depth looks okay, right? 3 millimeter. But when you look at the LAO view, this often happens, right? This looks a little bit shallow in LCC side. This often happens. You agree, right?
Yes, because of the flexibility of the catheter.
Yes.
It's very flexible, very soft, so it goes towards the outer curvature and then tends to be in this position quite often.
Yep.
And
actually,
let me ask you, if you are in that situation and if you see that it's shallow, isn't it a case to use that distal opening technique? Because as you start deep, you're going to pull on the system.
So that's also one of the solutions of this phenomenon, because there's no other way to fix this LCC shallowing, I think. So that's the one option. But so like just Yohei said, I have this figure. Like this is just Yohei just explained. This is stent flame, right? This direction is not coaxial to the aortic root. Because this device doesn't have a spine. So this is very flexible. So when you push, the shaft will be placed along with the outer curve of the aortic root. And when you open the device will be expanded further upward direction, like this orange or yellow arrows, right? So that makes it LCC shallowing. If you have a spine, actually, I think device will be opening like this direction because spine itself makes the shaft to be straightened, right? So that's the different from other device. I think this is the key of the this device. To solve that, actually push and pull is gonna be the way to do it. So this is a delivery of the device in LAO view. You have to push the device into the LV. But you push a little bit further more than you want it to be first. Like this is 3 millimeter now, but I'm gonna push a little bit more, like 7 millimeter without opening, right? Push, and finally pull it back to where you want to place, so that it goes 3 millimeter depth. And this is a 3 millimeter position while you are pushing. This is same 3 millimeter while you are pulling. You see a difference?
No, not much.
Yeah.
The axis of the catheter is different, but the depth.
Yeah, but you pull without opening. This is, I think, when the device position is determined with the pull, maybe device will be better aligned with aortic root, which makes the device more coaxial. I think this is one of the one of the strategies to do this implant this device. So this is our initial experience with only 32 cases, but we have 32 performed this device implantation, and only one case had a pacemaker implantation. And then we had 20 or 30 more cases, but none of the patient had a pacemaker in at the moment. So we have very low incidence of pacemaker implantation. And also, I heard that Yohei's institution is also very low percentage of pacemaker implantation.
2%.
Yeah.
Navitor, yes.
Okay, yeah. So thank you very much. This is my key slide, and no, this is a summary slide, but this is all I said already. Thank you very much.
Thank you.
Thank you. So, thank you, Gaku. I think you nicely highlighted the very important point, how to optimize this device, how to make it coaxial as much as possible, and some tips and tricks to avoid the conduction disturbance. So obviously, it's better to avoid the conduction injury while deploying this valve. So we have limited time. Lars, do you want? Yes, please.
Yeah, throw him.
Okay.
I mean, this was a super good lecture, good discussion, and yes, the device have no spine. You know, another device which I have a spine. The problem is here that you will always be very vertical. You're always going to land a little bit deep on the left corner side. Here, you can actually adjust it by pushing on the wire, pulling on the system, so you have coaxial alignment. So back to the question about pacemaker rate. And I think you touched on all the important points why you have a relative high pacemaker rate for the time being. One thing is non-uniform expansion or incomplete stent opening. And the reason you see this with this platform is that nitinol is a very complex structure. You can design this force as you will. You can have a high opening force or low opening force. The radial force, when it's anchoring in the annulus, is almost the same for all self-expanding. But the opening force, when it starts to coming out of the capsule to it have annulus contact, is different. This valve have a low opening force. And the trade-off with a low opening force is that you need to do more pre-dilatation. If you have a high opening force, you need less pre-dilatation. But on the other hand, you're going to have a more stiff system, a less flexible system. So the price for having a flexible system is a low opening force. For some reason, over time, people went away from pre-dilatation. In the beginning, everyone was pre-dilating, and then with the Evolut platform, we stopped pre-dilating, and then we went back again, and we ended up with a don't exceed the minor axis. I don't know where it came from, but this was the way we did. And it's actually also, you show the best clinical practices say do not exceed the minor axis. I think that's a mistake for this platform. You need more aggressive pre-dilatation. If you look at another platform, which also have less opening force like the Accurate, they are doing much more aggressive pre-dilatation. So right now, the IFU is going to be changed from do not exceed the minor axis to do not exceed the perimeter derived. If you do that, you're going to see less non-uniform expansion. You're going to see less incomplete stent opening. And incomplete stent opening is an issue because people don't trust that the valve is going to stay. They're afraid they're going to go very high with the valve, and when you release it, it's suddenly going to sit a few millimeters higher. If you do more aggressive pre-dilatation, you're going to see less non-uniform expansion. You're going to see a much more stable valve which is not going to open. You're also going to get away from this people distal opening. Of course, it's not what you want. You don't want to fiddle around down in the LVT with the system. And one thing which is also going to be changed with this valve is that if you look at the delivery system, next to the nose cone and before the stent frame comes, there is a dead space. There's an empty capsule, which of course at 5-6 millimeter too long system, that's going to be taken out. That was introduced because the FlexNav system was able to host both the portico valve and the navitor, and the portico valve was longer. So it's going to be shortened about 5-6 millimeter. So I think more aggressive pre-dilatation with more stable position will change it. And also I think this shorter delivery system is also going to make a difference. So I'm sure that the pacemaker rate will come down as this IFU is going to be rolled out.
Exactly. So yeah, thank you so much for touching this critically important points, and I can't agree with you more because we learned a lot from the early days that, as you mentioned, if the valve is not expansion well, after the final release, it may move. And I think that we heard a lot about the early experience centers that had that kind of experience. So there was some concern about implanting this valve. So maybe that was the reason they started to implant slightly lower. But as you mentioned, if it's really well dilated and well expanded, I think it stays as it is, even if it's in like 2 or 3 millimeter depth. So are you having trouble?
Yeah. I'm struggling. But I think my main, if we can see the smart screen, the main message is that we need to refine the guidelines for this device, honestly. We need to pre-dilate aggressively and not exceeding the mean diameter of the annulus. What I learned from you, and I'm going to do that starting from Monday, if we can see the smart screen, could you project the smart screen for
the big screen?
for 1 minute on the big screen? So the first movement, what you said, is that after the pre-dilatation, we bring the catheter within, just below the annulus, forward movement, we push. And we locate the 3 markers exactly where we aim at. The second movement is to pull, still keeping the marker exactly at target. And then we follow the expansion, the final expansion. So we aggressively pre-dilate, forward push, adjusting the tension on the wire. Before we start to expand, we pull, just to correct the trajectory, and we maintain the device where it is. So this is homework for Abbott now. They need to refine the guidelines for the deployment of the Navitor. It's already in the guidelines. So we need to follow the guidelines. Maybe one comment from you guys before we move to the last talk, because it's a lot of discussion, but we have to.
So I think this is very important, right? We saw that in the Accurate trial as well, that less pre-dilatation, more problem. The other way to think about it is, other than hostile anatomy, where you're worried about annular injury, you could simply think of what sapien size or balloon expandable size you use. We inflate it with balloon, it doesn't cause any harm. So then 1 millimeter less could be the size of the balloon. And that probably will help as well in terms of stability and expansion.
Exactly. It's time to rethink the balloon size for this platform. So thank you so much, Gaku.
Thank you very much. So Angus, for the last talk about the redo procedure, how to plan for that. And
yes, thank you. Thank you for having me. It's my great pleasure here today. And my task today is how to select the optimal index valve for patient, especially considering the lifetime management. I have nothing to declare. As we now doing a lot more TAVI for those who have low-risk patients, of course, we can expect that we are doing a lot more younger patients. Unlike those mentioned in guideline, if you look at the data, the US data, actually not just those older than 65-year-old has a lot more TAVI. Even those younger than 65 having more and more TAVI nowadays. And so lifetime management is getting more and more important, and one of the most important will be the coronary access. From previous landmark trial data, we know that the prevalence of coronary artery disease among those AS patients range from 15 to 81%. Those older trial tends to have higher percentage of coronary artery disease, while those low-risk trial has lower coronary artery prevalence. And interestingly, those post-TAVI patients, the incidence of acute coronary syndrome range from 4.7 to 10%, but only 1.9 to around 5% of these ACS patients could receive coronary angiogram or EP sign afterwards. Of course, this a lot of time is due to this patient selection problem. If you look at the Sweetheart trial, you notice that only those younger than 60 at 70 had a higher chance to receive coronary intervention after TAVI, but not those who are older than 80s. So as we are doing a lot more 65-year-old or younger patients, we can expect that we have a lot of patients who require to have coronary access after TAVI. There are several factors that can determine whether we can do a successful coronary access. no matter it's patient factor, procedure factors, device factor, or whether we do it safe in TAV or TAV in TAV. But when we look at the data, the CareFit registry tells us, which is actually the prospective multi-center trial who try to see whether coronary reaccess is easy after the TAVI. But of course, we know that not all TAVI devices are equal in terms of coronary reaccess. The balloon expandable will be the easiest, but self-expandable, of course, is a little bit difficult. But even for those who, among those tall frame TAVI devices, the chance of coronary reaccess are not equal. So the design of the valve definitely will change whether we can do the coronary reaccess. The Sweetheart registry once again assessed whether intra-annular or super-annular valve design can change. Does it matter? Yes. The total fluoroscopic time for those who are having intravalvular self-expanding TAVI device is much shorter if we need to do the pulmonary angiogram or PCI. So, and another important factor is not just the level of the leaflet, but also the cell design. And the cell size not just determine how easy you can have the catheter put through the frame, but also how easy you can manipulate the catheter after you have it across the same frame. If you try before, you can appreciate this is actually particularly important if you need to cannulate the right coronary artery, because sometimes it's difficult. Even you put through the cell, it doesn't go into a selective coronary injection. If we look at the different cell designs, the old generation e-fluid, the cells can only accommodate 10 French catheter, while the allograft can accommodate 12 French catheter. The Nephrotor vision is similar to the Nephrotor or portico device. The cell size are much bigger, although the latest generation FX Plus, they also have 3 large cell windows, they call windows, that can accommodate up to 20 French catheter. But we need to, this is not unlike the Nephrotor device because all the cells are equal in for the Nephrotor system. So based on all this special design, when we look at the COMFORT registry, which presented last year in PCR, for those who have a Nephrotor implanted in a random fashion, which means they didn't care about whether we have commercial alignment, up to 97% chance they have coronary cannulation. But bear in mind, this is not all of them have selective coronary cannulation, but we just need to have a non-selective is still good enough for PCI. Of course, as we are treating more young patients, we also need to consider what happens if the TAVI device degenerates and we need to put in another TAVI device. And at this moment, the height of new skirt will definitely matter when we do the coronary reaccess. And because of the first intra-annular design and a much lower skirt height, by the benchmark test, we know that the new skirt height is one of the lowest for those who have a Nephrotor system or portico system implanted. And even we choose a correct device, but of course, we already mentioned before, we don't always forget about the commercial alignment. Even with the older generation, the Nephrotor valve, we can just look at the commercial port. We can look at both the coplanar view and the cups overlapping view, make sure we have one of the commercial poles over the right side of the screen during the cups overlapping technique, which is very similar to what we do if you play around with the CT in the Fremantle system. It's just opposite, because we need to have 2 poles over the left side of the screen, while only 1 pole over the right side of the screen. But with the new Nephrotor vision, because the radial opaque marker is also at the same spot under the commercial pole, so it can give us much easier, much clearer vision of how good we are in the commercial alignment. And because the device is so stable, the hemodynamic was so stable, during the deployment, if we don't get a good commercial alignment, we can try to recapture it and then rotate it a little bit and do it to make sure we have a perfect commercial alignment, especially for those who are young patients, have a higher chance of coronary reaccess afterwards. So I would like to share one of a previous case with you. This is an 83-year-old gentleman with bad COPD who presented with symptomatic aortic stenosis. The CT shown there's good annular signs with huge sinus oversuffer. However, the left coronary height was only 6.8 millimeter for this patient, with the leaflet length more than 14. So we definitely think that this is a high risk of having coronary obstruction after TAVI. But we were a little bit hesitant to do the basilica for this patient because of the bad lung. The patient couldn't tolerate a prolonged procedure. So we decided to put in coronary wire and do the IFIS and see whether we have good, we have high signs of coronary obstruction. Before we start deploying, we need to make sure we have good commercial alignment. And after implantation, we also assess whether we have leaflet obstruction, sinus sequestration with IFIS. We deliberately deploy the device a little bit lower as what we normally do because of the low coronary height. But even with that, we try to do a coronary reaccess. We start this imaging, and actually we can do it within 10 seconds. So ladies and gentlemen, as an indication of TAVI expand to low-risk patient, more younger patient will receive TAVI, and lifetime management is an important consideration. The need of future coronary access is important and is expected to increase in those post-TAVI patients. With intra-annular leaflet, large cell design, and low nail skirt height in terms of future TAVI and TAV procedure, makes the navigator valve as an attractive option for this patient. Thank you very much.
Thank you, Angus, for an exceptional talk regarding both coronary access and the future potential lifetime management, potential TAVI and TAVI in the future. So quick question to the audience. Who has experience post-Navitor PCI? Okay, some of them. So...
Was it easy?
Whoa, 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 whoa. This is definitely Didier's fault.
Sorry.
Please share your experience.
It's very easy to access coronary, left coronary system, after Navitor system. And one question for you, if you access. When you stay engaged with guide extension and guide with the Navitor deployment and when the coronary height very low, I think this door always open when we engage with guide extension with Godzilla, and I think it's a little bit risky input go out without chimney stenting for me.
So like, when you do a chimney,
when we do this, we see your case now. It's for me it's a little bit risky because if you go out and after this maybe a little bit risk and you don't engage the guide catheter properly for left side. If the coronary height low than 7 millimeters.
Actually, during our case, we put in a guide extension. We specially choose a guide extension that is thinner. And because the IFIS catheter we use is the Terumo IFIS, is high density IFIS. We need to turn down the frequency of the IFIS so that we can see through the guide extension. But during the valve deployment, we deliberately pull out the guide extension, not up to the ascending order, just park it outside the coronary ostium, so that when the valve deployed, the guide extension will not damage the coronary, but we save some space for us, just in case anything happen, we can put in a stent inside.
I ask because no many cath labs in my country use IOS because they don't have IOS, and without IOS go out it's risky. And what you recommendation for this moment must be stent, deploy stent if you don't have IOS in this situation.
So I think the question it can be answered in two ways. One is if you have low coronary height, long leaflet like this, and this valve being intra-annular with large cells gives you the best protection. That's one thing. And the second thing is you're asking that if you don't have IVUS and you're still worried, I think you could do a few other things like maybe selective angio of that sinus, make sure you have good distance, but if there is doubt, then of course I think you should deploy a stent just at the orifice rather than getting it as a chimney coming up. So I think there are ways to do it, but this, Didier, you will agree that being intra-annular with large cells, probably least risky option in this situation.
And the risk of jailing the guide deal or the extension is quite low. It's not virtual, it's never zero, but you can do it quite safely. I'm more afraid of jailing the guiding catheter, particularly when you have a calcified sinotubular junction. Yeah, most of the time the extensions are more hydrophilic, so they glide quite easy.
Okay, so lastly, let's talk about the TAV and TAV, potential TAV and TAV. So Vinny, there's no one except you to answer this. So you've been have large experience assessing the potential combination, tall and short, all those combinations. So regarding this Navigator platform, how would you anticipate the feasibility and its inherent risk for future TAV and TAV?
So I think this being intra-annular, although with slightly tall leaflets, we are currently doing a project on this exactly to understand what the implications will be. But I think also we have set up some experiments to understand, can you implant slightly lower and what leaflet overhang you can accept. Of course, the leaflet overhang on this will not be tremendous because you can just implant at node 2, so to speak. And then the geometric opening area will be, of the overhang will be bigger than the geometric opening area of the valve. So it's promising in terms of that. And I think once commissural alignment becomes more reliable, of course, it adds another dimension to the lifetime management.
So if we consider to implant Navigator in a relatively younger and longer life expectancy population, we should try to consider implant slightly lower with achievable commissural alignment, if possible.
Right, I think that's going to be philosophy for most of the TAVR devices, right? And the main question for intervention community is, there is a school of thought which says first implant, just worry about that, we'll sort out the second implant. And the other is, match it, especially in younger patients, so you don't close the door and make the second procedure more complicated. Otherwise, me and Minoru are ready to operate this patient. It's never a problem.
That was another question maybe for Minoru. We have a patient with a failure of that platform. The patient is still youngish. And and as a heart team, you say, I'm going to explant that valve. Do you expect it to be easier because of the softer, lower radial force, less metal? Or do you think that you're going to get this aortic root replacement once again?
Yeah, thank you for your question. I haven't done explant of Navigator yet, but I guess it's going to be easier compared to the Evolute system. You answered everything actually, because of less radial force and less amount of a metal frame. So yeah, explant might be a good option for young patients. Yeah.
So because when we talk about lifetime management, it's all about the sequence. So it's not 100% redo TAVI. It could be TAVI, explant, and then valve in valve for some patients.
That's right. So I guess it's time to wrap up. And Didier, could you kindly summarize our session, what we have learned today?
Yeah, I think it was a fantastic session. I enjoyed it a lot of discussion. So we discussed several challenges of contemporary practice. What do we do with patients with challenging peripheral vasculature? We've discussed about the features of the FlexNav system. That is quite an asset in terms of navigating extremely calcified or small vessels, as you said, your way. We've discussed about the secondary access, the alternative accesses, particularly the direct axillary access. It's still a platform that is suited to that. And I pretty much enjoyed the discussion about small annuli because it's really something that means something in Asia. So small annuli and what we can expect from this type of platform once again. And the pacemaker, I think that was quite kind of central because there is a need of refining the refinement of the technique of implant to make sure that we can get what you have, a single-digit pacemaker rates with that platform. That is quite exceptional. So it means that we have to learn from you. And what you have just demonstrated in terms of technique makes sense. So let's go back home and work on that to try to refine the technique. And we could discuss at last lifetime management of the patient and the potential for that platform to be the first choice. And then we have other options that are still open. So very intense, very nice discussion. Superb panel as usual. So you guys were fantastic. Thank you for attending that session. Thank you, Yoe, for moderating with me. Thanks to Abbott for hosting such a very dynamic and interesting, impactful symposium. It's not over. Other sessions.